Welcome to the deep dive. We cut through the noise, get straight to the insights you need. And today we're really undertaking a complex analysis, high-stakes modern drug therapy. We're talking biological response-modifying drugs, BRMs, and disease-modifying antirheumatic drugs, or DMARDs.
Yeah, these are definitely not your grandfather's drugs. It's a real shift. We're moving, away from just general chemical toxicity and more towards delivering biological information, basically. BRMs, DMARDs, they represent a pretty fundamental strategic change in pharmacology. They don't just, treat symptoms or kill cells indiscriminately. They actually reprogram the body's own defenses against things like cancer, chronic inflammation, autoimmune diseases.
Okay, so our mission today is clear. Break down the science behind this whole revolution. We'll focus on the immune system basics first, then the major drug classes, and importantly, their unique dangers and the absolute clinical must-knows for anyone handling these potent meds.
Right. And to really get how these drugs work, we need a quick look at the system they're designed to manipulate. The immune system, the whole defense network is basically the surveillance system. Its job, distinguishing self from non-self. Anything foreign, that's an antigen. And interestingly, even cancer cells, which are technically oocysts but mutated, they often display what we call tumor antigens, signals danger.
Okay, so the body detects non-self, and it has two main ways of fighting back, right? Can you walk us through those?
Certainly. Think of it as two collaborative armies. They work together. First, you've got humoral immunity. This is driven by B cells. They're born in the bone marrow. Now, when a B cell bumps into an antigen, it recognizes, it transforms, becomes a plasma cell. Think of it like an antibody factory, just churning out antibodies, those immunoglobulins, IgA, D, E, G, M, all designed specifically to neutralize that one particular threat.
And those B cells, they're also responsible for the memory cells, aren't they? The ones that stick around. So the next time you encounter that same threat, the response is faster, stronger. Pretty clever design.
It really is. Biological efficiency. Now, working alongside that antibody factory is the second army, cell-mediated immunity. This relies on T cells. They mature in a different place, the thymus gland. And these T cells, they're your direct action forces, special ops.
Special ops, I like that. What are their specific roles then? What jobs do they do?
Well, they generally fall into three main types. First, the cytotoxic T cells. These are the direct killers. They find the target cell and boom, lysate, rupture it. Then you have the T helper cells. Think of them as the field commanders, the generals. They direct the whole operation, coordinate the attack.
Okay, killers and commanders. And the third type?
That would be the T-suppressor cells. These guys provide the crucial break. They limit the immune response so it doesn't go overboard and start attacking healthy tissue. Autoimmunity, right?
Ah, so that balance is really important.
Absolutely key. In a healthy system, you generally see about a 2-to-1 ratio. T helpers to T suppressors. And here's something critical for our discussion. If those T suppressor cells become too active, too dominant, they can actually dampen the anti-tumor response. Basically, let cancer slip through the net. So this imbalance, it's often exactly what these newer drugs are designed to either correct or sometimes even exploit.
That makes perfect sense. And it sets us up nicely for our first major drug class, the ones designed to support the army. Hematopoietic drugs. These are so important, especially for cancer patients dealing with chemo side effects, yeah?
That's exactly right. These drugs aren't about killing cancer directly, not their job. They support the body's own factory, the bone marrow, its ability to replenish crucial blood components. That whole process is called hematopoiesis. And the drugs themselves, they're basically synthetic versions of our natural growth factors, made using recombinant DNA technology.
So the mechanism is all about the bone marrow then, targeting those progenitor cells.
Precisely. They latch onto receptors on those immature progenitor cells in the marrow. And they basically give the instruction, okay, time to mature, multiply, and become active red blood cells, white blood cells, or platelets. This is just vital for cutting down recovery time from anemia, and maybe even more importantly, chemotherapy-induced neutropenia, low white cells.
Okay, and we mainly see two types here in practice. Erythropoietic drugs for red blood cells like epoetin alpha, and then colony-stimulating factors, CSFs, for white blood cells. Filgrastim, GCSF is a big one there.
Filgrastim is a real workhorse. It specifically boosts granulocytes, especially neutrophils. Neutrophils are your frontline infantry against bacterial and fungal infections. So by keeping those neutrophil counts up, doctors can often stick to higher, more effective chemotherapy schedules. It's enabling.
But if we're pushing the bone marrow that hard, stimulating all that production, there must be side effects. What are we looking at?
Yeah, you don't get that kind of boost for free. The most significant and often the most common side effect is actually bone pain. You're literally forcing rapid cell growth inside the bone. Patients often feel that. Deep aches sometimes. Other, maybe less severe things can include fever, muscle aches. And we need to remember key contraindications. For epiwidin, darbepoetin, uncontrolled high blood pressure is a no-go. And for filgrastim, you absolutely avoid it if there's a significant number of myeloid blasts, like over 10%, risk of feeding the tumor.
Right. And speaking of safety, this brings us to that really critical timing rule for filgrastim. This is super important. If a patient's getting myelosuppressive chemo that knocks down the marrow, what's the rule?
Yeah, this is a high alert situation.
Yeah.
Non-negotiable, really. Filgrastim should not be given within 24 hours, either before or after the myelosuppressive chemo. Think about it.
Yeah.
You can't send in the rebuild crew while the demolition team is still swinging sledgehammers. The drugs just fight each other. They antagonize each other, potentially making both less effective.
Yeah.
Or worse.
Got it. Okay, crucial timing point. Let's shift gears now to the second major class of BRMs, the immunomodulating drugs. These are the ones that directly tweak the immune response itself, starting with interferons.
Right, interferons. These are actually powerful proteins our own bodies make. They have antiviral properties, anti-tumor effects, and, as the class name suggests, immunomodulating actions. How they work is pretty neat. They can protect healthy cells from viral invasion. And in cancer, they can slow cancer cell replication, but also, crucially, they increase the expression of those tumor antigens on the cancer cell surface. Makes the cancer cells more visible, like putting a flag on them for the immune system to see and attack.
Interesting. So where do we see interferons being used clinically? Any key examples?
Oh, definitely. They're really important in managing some chronic conditions. Take multiple sclerosis, MS best. Specifically, the relapsing or remitting type. Interferon beta-1a and beta-1b are standard treatments. They seem to help by interfering with that dysfunctional immune attack on the nervous system that characterizes MS. But there's a trade-off, the side effects. Almost everyone gets flu-like symptoms initially. Fever, chills, headache, just feeling lousy. But the big one, the one that often limits how much drug a patient can tolerate, is fatigue. Can be quite debilitating.
Okay, fatigue. And I've also heard about some interferons being pegylated, like p-interferon alpha-2a. What's that about? Why pegylate them?
Ah, pegylation. That's a clever bit of pharmaceutical engineering. Basically, they attach this inert molecule, polyethylene glycol, PEG, to the interferon protein. This makes the whole molecule much larger. And what does that do? It acts like a slow-release mechanism. It significantly prolongs the drug's half-life in the body, slows down how quickly it's cleared from the plasma, and result. The drug stays active longer, so the patient needs fewer injections, maybe once a week instead of multiple times. Huge convenience factor.
Clever. Okay, next up within immunomodulators, the real targeted therapies, monoclonal antibodies. You know them by the MAB suffix.
MABs, yeah. These represent a huge leap in precision medicine. Each MAB is engineered to target one very specific molecule. A single abnormal protein, maybe a receptor on a certain cell type, and that incredible selectivity is their big advantage. Because they're so targeted, they tend to spare healthy cells, which generally means fewer of those broad systemic side effects you see with traditional chemotherapy.
And we see them everywhere now, it seems. Autoimmune diseases. You mentioned TNF-alpha blockers like adalimumab, infliximab for RA, Crohn's.
Yeah, exactly. Highly effective there. And in cancer, the mechanisms are incredibly varied. It's fascinating.
You've got bevacizumab, for example. It targets VEGF, vascular endothelial growth factor. Basically, it stops tumors from growing new blood vessels, effectively starving them. Anti-angiogenesis, or trastuzumab, that one says. It targets the HER2 protein, which is overexpressed in certain, often aggressive types of breast cancer. Then there's coctizumab, targets the CD20 antigen found mainly on B cells. Huge for treating certain lymphomas, like non-Hodgkin's.
Incredible specificity, but with that power comes specific risks too, right? What are the big safety flags clinicians need to watch for with MABs?
Definitely. High power, high stakes. First off, acute infusion reactions are a major concern. Fever, chills, difficulty breathing can happen quite quickly during or shortly after the infusion. That's why patients getting MABs are almost always premedicated. Acetaminophen, diphenhydramine, usually. And because most MABs work by influencing or suppressing the immune system, the risk of infection is constant. Not just common infections, but sometimes serious opportunistic ones too. The source material specifically calls out infliximab, warning about potential fatal TB or serious fungal infections. Needs careful screening. And another big one, trastuzumab, the HER2 antibody. It carries a significant risk of cardiotoxicity, heart problems, requires close cardiac monitoring.
Wow, okay, lots to monitor there. Finally, within this immunomodulating class, we have the interleukins, like the agonist, aldesleukin.
Aldesleukin, yeah. This one is derived from interleukin-2, or IL-2. and it really pushes the immune system's accelerator pedal hard. Its main job is to stimulate the production and activity of what are called lymphokine-activated killer cells, or LAK cells.
Yeah.
These LAK cells are pretty amazing. They seem to be able to recognize and destroy cancer cells while leaving normal cells alone.
Sounds powerful. But this drug, it's known for one particularly notorious, really serious toxicity, isn't it?
It is, and it really highlights that risk-reward balance we have to constantly weigh. Aldesleukin therapy can be severely complicated by something called capillary leak syndrome. Basically, the tiny blood vessels, the capillaries, they lose their integrity. They become leaky. And massive amounts of fluid leak out of the bloodstream and into the body tissues. Everywhere. We're talking huge fluid shifts, weight gain of 10, even 15 kilograms very quickly. And this can rapidly spiral into life-threatening respiratory distress or heart failure. It's an emergency. That's why patients on aldesleukin need incredibly close, intensive monitoring, usually in specialized units. The good news is it's usually reversible if you stop the drug, but you have to catch it fast.
That is a stark example. That potential jump from cure to crisis really underscores the power we're dealing with. Okay, let's shift our focus slightly now to drugs specifically aimed at chronic autoimmune diseases like rheumatoid arthritis, the DMARDs, disease-modifying antirheumatic drugs.
Right, DMARDs. These are really the cornerstone for treating RA long-term. And it's crucial to understand how they differ from, say, NSAIDs or corticosteroids. NSAIDs, the steroids, they mainly manage symptoms, pain, inflammation, swelling, short-term relief. DMARDs are different. They aim to slow down or ideally even halt the underlying disease process itself. They do this by interfering with the movement of those inflammatory cells, neutrophils, monocytes, macrophages, stopping them from getting into the joint and causing damage. One key thing, though, they're slow-acting. Can take weeks, sometimes months, to really see the benefit. It used to be called Sayre's slow-acting.
Slow-acting antirheumatic drugs, yeah. So what are the key examples here? Let's start with the older conventional ones.
The absolute classic conventional DMARD is methotrexate. Now, it's used in much, much lower doses for RA than it is for cancer. But this leads to a huge safety point. Methotrexate for RA must be given once per week, not daily. There have been tragic, even fatal medication errors because someone mistook the schedule. It needs constant reinforcement, and because it can suppress the bone marrow, even at low doses, patients often need to take folic acid supplements alongside it.
Okay, methotrexate, once weekly. Got it. And then there are the biological DMARDs, many of which are MABs we've already discussed.
Exactly. Many of the TNF blockers, like etanercept, that's another big one, given subcutaneously, fall into this category. There's also abatacept. Different mechanism, it inhibits T-cell activation. And abatacept comes with a specific pre-treatment requirement because it messes with the immune system and can reduce vaccine effectiveness. Patients really need to be up to date on all their necessary immunizations before they start the drug. And generally speaking, for almost all DMARDs, active infections are a major contraindication: bacterial, viral. You definitely don't want to suppress the immune system if it's already fighting something serious like active TB or even latent TB or chronic hepatitis without proper management.
Makes total sense. Okay, we've covered what these drugs are, how they work, the risks. Now let's bring it home for the clinician, the nurse at the bedside. When you're administering these high-alert meds, what are the absolute key things to focus on, the nursing process points?
Right. Practical application. Assessment is key, obviously, but it needs to be specific. Before giving any BRM or DMARD, you absolutely need baseline vital signs. Temperature is critical fever, could be your first, maybe only sign of a brewing infection. You need baseline blood counts, white cells, platelets, red cells. Why? Because so many of these drugs directly impact the bone marrow. We need to know where we're starting from.
And you mentioned kidney and liver function too. Why the intense focus there?
Because these complex drugs are often processed and cleared by the kidneys and liver, and some can be toxic to those organs themselves. So having up-to-date kidney function tests, BUN, creatinine, and liver function tests like ALT, ASD is essential. We need to know the patient can handle and clear the drug safely. Oh, and always, always double-check for allergies, not just to the drug itself, but sometimes packaging components. Some forms of etanercept, for instance, have latex in the needle cover. Need to ask.
Good point on latex. Okay,
Yeah.
Assessment done. Now, implementation. We hammered the filgrastim timing rule. What other critical safety checks are needed when giving these drugs?
Aseptic technique is absolutely non-negotiable. Many patients will be immunocompromised. For the MABs especially, always anticipate infusion reactions. Be ready. Have orders for pre-medication, usually acetaminophen and diphenhydramine, and know when to give them. And infection surveillance is ongoing. It doesn't stop after the first dose. Monitor constantly for any sign of infection. Fever is the big one generally. A temp over 38.1 Celsius, about 100.5 Fahrenheit, needs immediate reporting. And for patients who become severely neutropenic, you might even need reverse isolation precautions to protect them from us.
Right, protecting the patient. Finally, what about patient education? What absolutely has to be communicated before they go home?
Several key things. We need to warn them about potential CNS side effects, like dizziness or fatigue, especially with interferons. Advise caution with driving or operating machinery until they know how the drug affects them. Contraception is huge. Some of these drugs can cause birth defects, and the recommendation for effective contraception might extend for months, even up to 2 years after stopping the drug for some agents. Critically important. I'm sorry to sound like a broken record, but it's that important. Reinforce the once-weekly schedule for methotrexate. Make sure they understand why. Check their understanding. It saves lives. And that really brings us towards the end of this deep dive. So to quickly recap the big picture, BRMs fundamentally modify the body's own response, rather than just killing cells broadly. Hematopoietic drugs, they support blood cell production. Immunomodulators, the interferons, MABs, interleukins, they offer these really targeted attacks on disease processes or pathogens. And DMARDs, they focus on slowing or stopping the underlying disease in conditions like RA. From a clinical standpoint, success with these agents really hinges on supervigilant assessment, understanding the precise timing rules, and just rigorous infection prevention and monitoring.
It's fascinating. These drugs really do represent a massive technological leap, don't they? Moving from generalized toxicity to highly specific interventions. But as you've highlighted, they shift the clinical challenge in a big way. It's less about managing the sort of predictable side effects of traditional chemo, and more about managing the incredibly powerful, sometimes unpredictable consequences of deliberately altering the body's own complex defense systems.
That's perfectly put. It really is a high-wire act in modern pharmacology.
Exactly. And maybe that's the final thought for you, the listener, to really chew on. When you have a drug like aldesleukin, that holds the potential to cure metastatic cancer, but at the same time carries the risk of inducing a potentially fatal condition like capillary leak syndrome. How do we, as clinicians, ethically and safely navigate that razor's edge, managing that fine line between miracle cure and sudden crisis, that constant, careful balancing act that really is the core challenge and maybe the art of using these powerful BRMs and DRMs effectively? Thank you so much for joining us for this deep dive. Until next time.